protrusive acetabular. It's intrapelvic displacement of the acetabulum and the femoral head. So the femoral head projects medial to the ilioischial line or cohlar line. It is classified by Hurst et al. And probably 1 to 3, 3 to 5, and more than 5. Causes decreased bone density, like osteoporosis, osteomalacia, osteogenesis imperfecta, rickets, rheumatoid arthritis, and ankylosing spondylitis. Then is normal bone density, osteoarthritis, and idiopathic. Increased density, hypophosphatasia, and Paget disease. Regarding the etiology, you can talk about trauma, like cerebral fractures, infective, like septic arthritis, inflammatory, like ankylosing spondylitis and rheumatoid arthritis, neoplastic, like neurofibromatosis and multiple myeloma, metabolic, like Paget disease, osteomalacia and rickets, genetics, like autopelvis. Regarding the management, template is important to avoid offset and limb length discrepancies. Because of medial migration of femur, number 1, sciatic nerve is at risk. Number 2, hip dislocation might be difficult. Number 3, capsular incision should be extensive. Number 4, neck osteotomy might be needed before dislocation. Number 5, in severe cases, trochanteric osteotomy may be needed. Number 6, medial wall of the acetabulum is thin, therefore reaming with a large cup. The general principle is to bone graft the floor and lateralize the cup. Number 7, rim press fit. Using cementless shell or thin or deficient medial wall is not relied upon. Number 8, acetabular screws may be needed. Number 9, femoral head graft can be used to reinforce the medial wall. Number 10, reconstructive cages may be required. Anteprotrusive cage, Burr-Schneider cage. Intraoperative complications, fracture can happen, nerve injury can happen, bladder, ureter, bowel injury can happen, external iliac artery injury is a risk. Most common post-operative complication is loosening, migration of acetabular component. Other include dislocation, infection, and leg length discrepancy. Baghdadi et al. 2013. If the center of anatomical center hip rotation is 1 mm displaced, the revision rate increases by 24%. The problems with the acetabulum hip is 50% of loosening of THR if hip center is not corrected to the 10 millimeter of anatomical center.